Hi, I would like to take this moment to introduce myself. My name is Andrew Udkovich, and I'm a pediatric nurse and nurse practitioner. I've spent most of my career sitting at the intersection of clinical practice and nursing education, and I've worked clinically as an RN in pediatric hospital medicine, and then went on to practice as a pediatric nurse practitioner in both primary care and school-based health settings. From there, I did move into nursing education, and I've served as faculty at two institutions here in the Rochester, New York area. At the University of Rochester, I taught across the full spectrum of different types of courses, didactic courses, clinical rotations, lab, as well as simulation. And at St. John Fisher University, I served as the Graduate Simulation Center coordinator for their VR program for multiple nurse practitioner specialties. I had the privilege of leading the integration there of virtual reality into advanced practice nursing education. I would say that across both institutions, I've been privileged to have a front row seat to how students learn anatomy, and more importantly, I would say how they struggle with it. Um, After my time in academia, I did move on to a company called Oxford Medical Simulation, which is a healthcare VR company, and I worked there as an educational consultant and as account manager, and I was responsible for working directly with nursing schools and clinical education programs in hospitals to bring simulation technology into their curriculum. That role gave me an even broader view of the tools educators are searching for and the gaps that still exist in the solutions that are currently on the market. I currently work as a senior clinical product manager for TDS Health, which is a leading healthcare digital solutions company. And I continue to have my main focus be on how we build better clinical learning experiences through technology. What I want to address today is the question of anatomy education and its real world application. And it's been a problem that I've been thinking about from a lot of different angles, especially as I transitioned from the bedside to the classroom to now into the corporate environment. One of the questions that I think educators struggle with the most is what does it look like when a student can't apply idealized anatomy to a real patient? For me personally, I think the moment that always stands out to me is how students struggle during a physical exam. A student may have memorized the landmarks perfectly. They can label every structure on a diagram. They can ace the practical exam. Then they're standing at the bedside of a real patient in a clinical room and they freeze. It may be someone who is elderly or obese, has had recent surgery, has different comorbidities that could be affecting their anatomical landmarks, and the students freeze. The landmarks they memorized may not be where they expected them to be. I've watched students, for example, search for an apical pulse in completely the wrong location because the patient may, let's say, have a barrel chest. Or I've seen them miss hepatomegaly because they weren't able to adjust for a patient who had comorbidities or was significantly overweight. Their hands may be in a certain position that they thought that needed to be. The stethoscope was in a certain position they thought they needed to be. And when they aren't presented with the picture that's exactly like how it is in the book, they become uncertain and they lack the confidence to know how to progress in their exam. What I think is really happening in this situation is that their knowledge has become very image dependent. They learned anatomy in ideal conditions, the average body, clear borders, the textbook's presentation. And when that template doesn't match what they're seeing in front of them, their clinical reasoning and decision making stalls. The student doesn't know how to adapt, and they don't know how to understand the underlying structure and correlate that to what they're actually seeing or actually like seeing, feeling, or listening to in front of them. And I think that actually becomes a big patient safety issue. When a student is palpating in the wrong area or auscultating in the wrong field, it becomes missed findings. And those mixed findings, when a student is in a program, are just merely academic errors. But when they transition to actual clinical practice, those errors follow them into practice and become gaps in how they are able to clinically apply their anatomical knowledge. And that can ultimately severely impact patient outcomes. When I think about what's been missing from the resources available to my students, and specifically anatomical resources, the key word again that comes to mind is variation. Every atlas, every model, every simulation shows the same body. And that body typically doesn't walk through our clinic doors. Our patients are older, younger, larger, smaller. As I mentioned, they've had surgeries. They may have had chronic disease or a comorbidity. Their anatomy is a lived experience, and it definitely is not always normal. What's been missing is those resources that teach students to expect the abnormal, to expect diversity, tools that show them, again, let's say what a liver feels like in a thin patient and where it might be as opposed to an obese patient, or where to find that apical pulse in a patient that has COPD, or a radial pulse in a patient that has significant edema and heart issues. Personally, I think we need teaching resources and specifically anatomy teaching resources that normalize variation as the rule and not the exception. Because right now, I believe that we're teaching students to be confident providers under the most ideal conditions. And what we really need is for them to be competent and confident providers under the abnormal conditions. Thank you for your time. I really appreciate it.